From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to this JAMA podcast. I'm Dr. Kirsten Bibbins-Domingo, and I'm the editor-in-chief of JAMA and the JAMA Network. I'm joined today by Dr. James Stevermer, a family physician and the Vice Chair for Clinical Affairs, and the Paul Revere, MD, Professor of Family and Community Medicine at the University of Missouri. He is the medical director of MU Healthcare Family Medicine Callaway Physicians, where he practices and teaches rural primary care. His scholarly activities focus on dissemination and evidence-based medicine. Dr. Stevermer is also a member of the U.S. Preventive Services Task Force, and he's joining me today to discuss the new recommendation statement from the task force on primary care interventions to prevent child maltreatment. JAMA has published this recommendation statement and the evidence report on which the task force recommendation is based. Dr. Stevermer, thank you for joining me here again today to discuss this work.
Thank you. I appreciate the opportunity to come and talk about this very important topic.
Jim, I hope you might begin by giving us a high-level summary of this recommendation statement. What is the letter grade, and what does the task force say about primary care interventions to prevent child maltreatment?
So clearly, child maltreatment, child abuse, or neglect, we'll use the term maltreatment, is a very serious problem, and we see a lot of children are suffering from this, and we want to do everything possible to reduce the risk of it. However, when the task force looked at the evidence, we ended up with an I statement, which is really not a recommendation for or against any particular interventions, but really a call for more research and study so we can better identify what might actually help reduce the risk of maltreatment. And I'd like to point out that we're really focusing on prevention of maltreatment in children who do not have a known history of maltreatment or who do not have signs or symptoms of that.
So that's an important clarification. We're talking about child abuse or neglect. Those are probably terms that will be familiar to a range of our audience, and that is encompassed all in the term maltreatment. So, of course, this is something that people will be aware of, but give us the context here. How common is the problem of child maltreatment, particularly as it might be presenting in the primary care setting, and who is at risk?
So unfortunately, this is a very serious problem. We're seeing lots of children who are victims of either abuse or neglect. And estimates in 2021, there was roughly 600,000 children who were victims of maltreatment, and roughly 1,800 children actually died as a result of that. So this is clearly a serious problem.
And I just want to clarify, the numbers you just mentioned from 2021 represent children in the U.S. only. Now, that's a lot of children we're talking about, and very serious consequences because some of the children you've described have died. Give us a sense of who is at risk.
So among children who are at increased risk, we see often age being a major factor, particularly for those under age 4, children who have special health care needs, children with a prior history of maltreatment, and also we see it more prevalent in female children.
I see. So I statements are very important ones because they signal to the research community we need more evidence. But they also can be challenging for us to understand in the context of clearly something like this where we would want to do everything we can to prevent this maltreatment of children. So how does the task force think about I statements? How do you think about I statements? And help us put it in context here.
You're correct that an important part of the I statement is to signal to the research community, we have gaps here. We can't make a solid statement. And so when I think about prevention and screening, there's a lot of recommendations and potential things we can do. When I'm in clinic, seeing my own patient panel, we're often got a lot of agenda items to address. And so I appreciate knowing which recommendations have the best evidence behind them so that I know that it's probably worth me taking the effort and time to implement this recommendation. So when it comes to I statement, it's basically what that's saying is we don't have enough evidence to guide clinicians as to what to do. That does not leave the clinicians that they should do or not do any particular interventions, but that it leaves it to their judgment because we can't give them a systematic answer that is evidence-based that can drive them to doing one particular thing or the other. So it falls on the clinician to look at the individual circumstances of, in this case, the child in front of them, as well as the resources that are available in their community, and use what tools they have possible to help prevent any maltreatment. And I also want to make a particular emphasis here that we're talking about children that are not known to have a history or have no signs or symptoms of abuse or neglect. Clearly, those children who have signs or symptoms need to be appropriately evaluated, make sure their safety is assured, and that clinicians will need to follow their state laws on what reporting needs to be done.
There are two big points that I hear in your response that are so important. The one is that the task force recommendations are always focused on patients who are presenting without signs or symptoms or without a family or member or somebody bringing a concern to a clinician or something like that. And so I think that's important. An I statement does not mean the task force is saying there's no evidence or don't do anything. You said, and I like the way you said it, it means clinicians have to use their best judgment in this circumstance because we don't have an evidence base to guide any specific type of intervention or recommendation.
Yes, that's correct.
Let's talk a little bit about the evidence. Is there any evidence out there? What specific areas create gaps in evidence that led to the I statement?
So there have been studies of multiple interventions, and I'll talk a little bit about what studies we looked at because we had a couple of criteria, so we did not look at all possible interventions. And one of the main criteria is the task force focuses on interventions that can be implemented in primary care or referred to from primary care. And some of the child maltreatment is actually a multifactorial problem, and so it is not surprising that we wouldn't have looked at every single study to prevent child abuse and neglect. We really focused on those in the primary care setting. Also, because of the way the task force approaches things, where we actually looked at outcomes that were related directly to child abuse or neglect. So we looked at outcomes that had some measure of child maltreatment. And so we're requiring studies that were in primary care settings or referable from there and had outcomes that measured some assessment of rates of child maltreatment. And what we found is really no clear signal of any interventions that would be beneficial. There are a fair number of studies actually that we found, but there really wasn't anything that led us to believe that a particular intervention was clearly going to be beneficial. We also tried to look at harms and also recognize that there are potential harms in this setting, and that wasn't always measured well. So we were left with enough gaps that we were unable to come to a recommendation for or against anything.
So it sounds like there were studies, but not ones that, when you reviewed the entire body of literature, were sufficient to allow you to say that the balance of benefits or harms moves in one way or the other. But also you suggested that you were very focused on both things that were done in the primary care setting and specific types of outcomes, which also narrows the pool of studies you might be looking at.
Yes, that's correct. And so some studies of, say, social support or reducing economic insecurity or housing stability might actually be beneficial interventions, but those really aren't something we can do in primary care. So we did not include interventions of that sort. Although we did look in that area, our real focus was on things that could be done in primary care or referable from there. So those programs often looked more like home visiting programs or education on appropriate parenting skills and discipline strategies, things that might improve the parent-child relationship and helping to develop improved coping skills for the parent. Those often included some parental education and then potentially home visitation programs or other such resources in the community.
And so the task force is calling for more research. Are there specific types of studies that the task force in particular would like to see?
Well, we would like to see successful studies of interventions that reduce the risk of maltreatment. This is a terrible problem, and we'd really like to have some answers to give to clinicians. But we focused on several areas. We actually have some concerns that measuring direct outcomes of maltreatment may carry some bias, and so we're worried that we may need to do things to improve the accuracy and reliability of tools to assess children at maltreatment. We were unable to find any tools that helped better identify children at increased risk, because if you're using limited resources to do an implementation, you want to target it at the people who are most likely to benefit. And so we also don't have any good ideas as to how best to stratify. We also don't have a great understanding of the role of the social drivers of health and how they can affect families, and how interventions in that space may actually help reduce maltreatment. So we had a wide series of questions that we'd like to get more information on.
So it sounds like researchers, there's a lot of work that needs to be done in this area. And in the meantime, we're talking about a very large problem. And I'd love for you to talk from your perspective as a family physician. Do you see this in your practice? And how do you think about an I statement and what you might be doing in your practice?
Certainly we see evidence of child maltreatment in our practice. I'm in a somewhat rural practice, and we have probably limited resources outside of our practice that we can use to help families that are struggling, which is unfortunate. It would certainly be nice to have those tools. If we have a child, obviously, who has evident signs or symptoms that raise the concern for maltreatment, we do follow our state law and report to the appropriate authorities, evaluate the child to make sure that they get the care they need, so that we can also investigate if further interventions need to be done, for at least medically, and let the legal system help do what needs to be done to protect the child outside of our office. We have to look at this case by case, and each child we can try to provide extra education where appropriate, but we don't have a clear system that we can use to reliably get families the extra resources when needed.
What I hear you saying is the call for more research also, it's not sort of an academic exercise. In your practice, I'm hearing that it's limited time and not many other resources outside of that practice. So knowing what works and being able to focus attention there would actually be helpful.
It certainly would be. And if we knew that a program was helpful, potentially more resources could be developed to that, and so that the resources would be available throughout all settings, not just places that have more resources.
I think that's such an important point, because we oftentimes talk about more research, but I think understanding the link between knowing that something works and that helping to help decision makers, people who have to figure out how to spend the money to put the resources towards evidence-based interventions, is actually one of the important outcomes that I think is the reason the task force tries to do this work.
Absolutely.
Well, Jim, I've really appreciated you taking the time both to hear your own perspective, but also really helping us to understand this recommendation statement, what an I statement means in the context of the important problem of child maltreatment.
Yes, this is a serious problem, and having that many children subjected to maltreatment, and even the 1,800 or so that die because of the results of their injury, are very serious problems. And we would love to be able to have interventions that we could recommend to clinicians. And so, again, strong call to the research community to get us the information that we can use to help guide clinicians. And I, again, want to point out that this focus is clearly on children who have no known history, signs, or symptoms of maltreatment, and that clinicians should clearly take steps and follow their state law and ensure the safety of any children they see that do have signs or symptoms of maltreatment.
Thank you so much. Thank you for that summary. I've been speaking with Dr. James Stevermer, a family physician and a member of the U.S. Preventive Services Task Force, about the new task force recommendation on primary care interventions to prevent child maltreatment. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.